The first time someone told you, it's just old age, it landed like a slammed door, sudden, cold, and final. For many older adults, those three words become a silence that hides heart attacks misread as tiredness, thyroid problems dismissed as slowing down, and medication side effects labeled as part of getting older. This video will pull back that veil. We will name 5 uncomfortable truths about how some doctors sometimes undervalue, simplify, or overlook the needs and voices of older patients. And we will show in clear steps how you can protect your health and dignity. If this kind of content makes sense to you, subscribe now. Block 1. It's just old age. How dangerous simplification hides treatable problems. There is a dangerous shortcut that creeps into clinical thinking, attributing new or worsening symptoms to age because the patient looks older or because multiple conditions exist. When a busy clinician thinks age explains it, the diagnostic engine slows and tests that could reveal a treatable condition may never be ordered. Imagine a man who begins to tire climbing stairs and wakes at night with breathlessness. If a clinician writes this off as deconditioning or normal aging, they may miss angina, heart failure, or an abnormal heart rhythm that is treatable, or a woman who complains her memory is fuzzier, labeling it as just getting older without checking thyroid function. Vitamin deficiencies, sleep disorders, or medication interactions may delay a diagnosis that could be partially reversible. This pattern is not malicious. Often it is a heuristic used to triage limited time, but it carries consequences. Age is a risk factor, not an explanation. The human body ages, yes, but aging coexists with illnesses that have distinct causes and treatments. The tragic error is in using aging as the final diagnosis instead of a starting point for investigation. How this affects decisions in practice. Tests may be deferred, referrals postponed, and treatments withheld because the clinician assumes little will change. That assumption sometimes becomes a self-fulfilling prophecy. When tests are not done, treatable problems remain hidden, function declines, and patients suffer needlessly. Practical steps for patients and caregivers, framed as empowerment, not instruction. Keep a symptom diary with dates and details. Specify what changed and when. Ask for basic investigations explicitly. Blood tests, ECG, medication review. Request explanations. What would make you consider ordering X test? Use objective language. I've noticed X started on this date and worsens with Y. When a clinician suggests it's just age, ask what other causes were considered and how they were ruled out. Always frame questions to invite investigation rather than confrontation. Block 2, the assumption they won't follow complex plans and how it narrows care. A second, subtle truth. Some clinicians, consciously or unconsciously, downplay treatment options because they assume older patients will not be able or willing to follow complicated regimens. This belief can remove choices from the table before a true conversation begins. Consider an older person newly diagnosed with cancer that has several possible treatments. If a clinician assumes the patient won't tolerate chemo, that patient may never hear about curative or life-extending options. Or consider anticoagulation for stroke prevention. Clinicians may avoid offering a therapy that would substantially reduce risk because they assume adherence or monitoring would be a problem. These assumptions can also affect rehabilitation and prevention. Complex rehab plans, multi-step surgeries, or intensive physical therapies sometimes are never offered because a clinician imagines an older adult will not complete them. The result is a narrowing of options and a potential loss of years of quality life. Practical actions to expand options. Share your goals early in the consultation. Travel plans, hobbies, caregiving roles, or milestones you want to reach. Ask, which of these treatments might help me meet that goal? Request a clear, stepwise plan. What needs to be done? Who will help? What support services exist? Home nursing, pharmacy delivery, physical therapy. If the worry is adherence, propose a trial with close follow-up, or inquire about simplified regimens or services that assist with medication management. Use stories to anchor the point. A composed vignette of a retired teacher who wanted to walk with grandchildren and was offered only conservative care, until she asked explicitly if rehabilitation could help. A small change in communication unlocked a path to meaningful recovery. When a clinician frames a recommendation as, "This is probably best for you," ask for the alternatives and their trade-offs. Request the reasoning. Why do you think this option suits me? If the answer is an assumption about age or adherence, gently push for evidence or propose a monitored trial. Block 3. Triage bias. When time and resources tilt care away from older patients, healthcare systems operate under constraints. Limited appointment times, crowded emergency rooms, scarce operating theaters. In that pressure cooker, triage and prioritization decisions are inevitable. But an underappreciated truth is that some of these choices systematically deprioritize older patients, consciously or unconsciously. The logic sometimes used, that younger patients have more potential life years, or that urgent resources should favor those deemed most salvageable, can quietly shift attention away from older adults who nonetheless have urgent needs and legitimate claims to timely investigation and treatment. Examples are common. An older person with chest pain might wait longer in triage because their symptoms are assumed to be chronic. Preventive screenings might be deprioritized because of perceived lower yield. Referral to specialist clinics may be slower when resources are thin. The cost of delay is real. Time-sensitive diagnoses, cardiac events, infections, embolic strokes require timely action. Even non-emergent conditions, when delayed, can erode function and independence. Furthermore, the emotional toll of feeling second class in the system compounds the physical effects. Patients who feel ignored are less likely to seek care, less likely to report new symptoms early. What can patients and families do when they face apparent deprioritization? Start by naming the urgency. I am concerned this could be serious because X started suddenly and is getting worse. Ask for expected timelines. When should we expect test results or follow-up? Ask whether there are faster pathways, urgent labs, expedited imaging, or telephone triage options. If you feel your concerns are not being addressed, request escalation. Ask to speak with a supervising clinician or request a second opinion. Document interactions. Keep a concise, dated list of symptoms, phone calls, and appointments. This record is a tool that clarifies the timeline and communicates seriousness. If you are in the emergency department and feel triaged away, calmly reiterate the reasons for concern and request reassessment if symptoms change. Block 4. When clinicians assume life goals matter less, conservative care has lost opportunity. There is a quiet theft that happens in exam rooms and ward rounds, the theft of possibility. It is subtle, often polite, and wrapped in clinical language, less aggressive, conservative management, prioritize comfort. Yet behind those phrases sometimes lies an assumption that an older person's ambitions, projects, and small plans are less worth fighting for. The result is that treatments designed to restore function, reduce pain, or enable meaningful activities are never even discussed. That omission is not neutral. It changes the arc of a life. Imagine a woman of 72 who has always loved gardening and planned to travel to see her grandchildren next spring. She develops severe knee osteoarthritis that limits walking. A clinician, seeing her age and comorbidities, recommends simple analgesics and advises her to learn to live with it. No mention of joint injections, referral to orthopedics, or targeted physiotherapy. No conversation about the possibility of a surgical option that, when appropriate, could restore mobility and make that trip possible. By not naming the options, the clinician has narrowed the horizon without checking whether the patient values broader horizons. Cardiology may recommend conservative management for symptomatic valve disease without discussing percutaneous or surgical options. Cancer teams may lean toward palliation without mapping out less toxic targeted treatments that align with the patient's goals. Orthopedic and rehab pathways may not be presented because of assumptions about recovery capacity. Underlying these choices are understandable concerns. Risks of interventions rise with age, surgical recovery can be harder, and multimorbidity complicates decisions. But risk and age are not the same. The ethical and clinical imperative is to align care with what matters to the person in front of you. Bring your own goals to the visit and state them early. I want to walk my daughter down the aisle next year. I want to travel to see my sister. I want to cut my own vegetables again. Naming a concrete, emotionally meaningful outcome forces clinical thinking to translate options into functional terms. Ask, which of these options would be most likely to help me reach that goal? And, if we choose a conservative route, what exactly will that look like in terms of function and timeline? Ask for functional endpoints, not just disease numbers. For instance, instead of only hearing that a medication reduces disease markers, ask how it will affect daily life, independence, and symptom burden. Request a rehabilitation plan that includes measurable targets, steps per day, distance walked, or tasks to regain. If an invasive option is on the table, ask about enhanced recovery pathways, geriatric co-management, or prehabilitation to reduce risk. If the clinician frames an option as probably too risky without outlining why and without comparing alternatives, ask for a second opinion or a multidisciplinary review. Often, different specialists bring different risk tolerances and different techniques. A newer, less invasive procedure or a rehabilitative plan might exist that your first clinician did not consider. Insist on shared decision-making. Decisions should reflect both clinical judgment and your values. If a clinician appears to make value judgments about your priorities, gently redirect the conversation. I appreciate the concern about risks. Can you explain the specific risks for me and the alternatives in the context of what I want to do? Block 5. Emotional wounds are part of the body. How grief, loneliness, and loss are too often minimized. The emotional landscape of aging is vast and often stormy. Loss accumulates of partners, friends, roles, physical capacities, social rhythms. That accumulation leaves scars that show up as fatigue, poor concentration, weight change, sleep disruption, more frequent clinic visits, and slower recovery from illnesses. Yet the emotional terrain is frequently mapped as normal reaction to aging and then left unmapped clinically. The consequence is that treatable and supportive interventions are not offered, and the body pays the price for what the heart carries. Consider a man who has withdrawn from social activities after the death of his spouse. He complains of worsening fatigue, poor appetite, and forgetfulness. These symptoms can be expressions of depression, complicated grief, or social isolation, all treatable by psychosocial interventions, medication when appropriate, or community support. If a clinician hears only normal adjustment and offers little more than reassurance, the underlying issue deepens. Depression in older adults is a major risk factor for functional decline, hospital readmission, and poorer outcomes after surgery or acute illness. Healthcare professionals sometimes miss these signals because they are trained to look for organ-specific problems and because mental health can be harder to quantify. Time constraints and lack of integrated services compound the problem. In some settings, clinicians worry that raising psychological issues opens a door they cannot manage in the time available. That is why a patient's voice and preparation matter. Naming emotional symptoms explicitly helps clinicians take them seriously. What to say and ask. Bring emotional concerns to the visit in plain terms. I've been feeling sad most days, I sleep badly, and I have lost interest in things I used to enjoy. Ask whether screening for depression or anxiety would be appropriate. Inquire about referral pathways. Can you help me connect with counseling, geriatric psychiatry, or community support groups? Ask about non-pharmacologic options first if preferred. Psychotherapy, social prescribing, exercise programs. And if medications are suggested, ask about side effects and monitoring, especially given interactions with other drugs you may be taking. There are also structural fixes worth asking about. Integrated care models that embed mental health support in primary care, routine screening for loneliness and depression in older adults, and stronger links between medical teams and community services. When clinicians are made aware that emotional health affects physical recovery and chronic disease management, they are more likely to make referrals and to monitor outcomes. If this topic fascinates you as much as it does us, comment what surprised you most so far. Comment, I choose to take care of myself. Block 6, Practical Toolkit, How to Reclaim Partnership, When to Ask for Second Opinions, and System-Level Actions. After naming the problems, the vital question is, what do you do next? The tools of advocacy are not mystical. They are practical, repeatable steps you can use whenever you face doubt or feel overlooked. These actions protect your health and restore the balance of partnership between patient and clinician. 1. Prepare and bring a concise dossier. Create a one-page summary with your main complaints, onset, and pattern of symptoms, a list of current medications, including over-the-counter and supplements, your medical history, and the goals that matter to you. When possible, include dates and objective markers. Weight loss of X kilograms since month Y falls on these dates, breathlessness that limits walking to Z meters. A one-page, dated summary focuses the visit and reduces the chance that important details are overlooked. 2. Use clear language and set expectations. Begin consultations by stating what you want to get from the visit. I want to know whether this symptom is potentially serious and whether tests could help. If diagnostic uncertainty remains, ask for a follow-up plan. If no cause is found today, when should I return and what will trigger a reassessment? 3. Ask about alternatives and contingency plans. For any recommendation, request the alternatives, likely outcomes, and what would prompt a change in strategy. If a conservative approach is chosen, ask how progress will be measured and what thresholds will trigger escalation. 4. Invite shared decision-making and multidisciplinary review. If a decision has large trade-offs, ask for a formal shared decision-making conversation with clear documentation of risks, benefits, and patient goals. For complex cases, request a multidisciplinary meeting: geriatrics, surgery, rehabilitation, palliative care, or a second opinion. Different specialists can offer different perspectives and options. 5. Bring an advocate. A family member or trusted friend who can speak up, take notes, and help remember details is invaluable. If you prefer privacy, ask the clinician to provide a written summary of the visit and follow-up steps. 6. Use documentation as leverage. Keep a dated log of symptoms, calls, and visits. If delays occur, a clear timeline can help when requesting escalation or a second opinion. Many clinicians and systems respond to documented patterns of decline or persistent concern. 7. Know your rights and local resources. Learn about patient advocacy services, ombuds offices, or senior care coordinators in your health system. They can help navigate appointments, referrals, and complaints. Community organizations, senior centers, and patient groups often offer navigation assistance and peer support. Block 7. Communication gaps in medical language that silences patients. Words in a clinic carry weight. They can open doors or quietly shut them. Medical language, when used without translation, becomes a wall. Phrases like, "we'll monitor," "age-related change," or "nothing urgent" sound polite, but can feel dismissive. For many older adults, this communication gap is not merely frustrating. It leaves them unsure, isolated, and less likely to raise concerns later. Clinicians sometimes default to technical shorthand because it is faster or culturally expected. Patients may nod, not from agreement, but from uncertainty or fatigue. Over time, these small misunderstandings accumulate into a relationship where the patient's lived experience is undervalued. Communication failures take many shapes. A physician might say, "It's probably multifactorial," and stop there. That phrase can feel like a dead end. A specialist might use acronyms and risk scores without translating how those numbers affect daily life. Discharge instructions may list medications without explaining why each one matters, how to spot side effects, or who to call with questions. For an older adult juggling multiple conditions, poor communication increases the chance of medication errors, missed follow-ups, and avoidable decline. Bridging these gaps is practical and achievable. Start by asking clinicians to explain in plain language what they mean by any technical term. Try a short script at the visit. Could you explain that the way you'd tell a friend? What will change for me day to day? If the clinician mentions uncertainty, ask what would clarify the uncertainty and when the review will happen. What test or sign would change your mind, and when should I come back? Request a written summary of the plan that lists immediate steps, who is responsible, and expected timelines. If you leave without clarity, telephone the clinic with specific questions rather than waiting for the next appointment. Active listening is a two-way street. Clinicians trained in patient-centered communication can change outcomes dramatically, but the change often begins when patients and families model their needs. If a diagnosis feels vague, repeat it back. "So you think my breathlessness might be caused by my heart, my lungs, or my medications. Is that right?" This reflective phrasing invites correction and ensures that both parties share the same mental model. Bring a notebook and use it. Write the clinician's words and then translate them into actions to take it home. When medication changes are made, ask explicitly, "What will I notice if this is helping? What are the side effects to watch for, and when should I call?" Cultural and generational differences matter too. Some older adults were raised to defer to medical authority and may hesitate to press for clarification. If this resonates, bring an advocate to appointments, a family member or a trusted friend, who can ask clarifying questions and help interpret the conversation later. In systems with patient portals, request that summaries and test results be sent there. Written information allows time for absorption and follow-up questions. Block 8. Medication complexity and polypharmacy. When good intentions become harm. As people age, the number of medications often grows. Each drug may be appropriate for a single condition, yet the combination can create interactions, side effects, and diminished function. Polypharmacy is an epidemic in older adults. Medicines meant to protect can, in aggregate, cause falls, confusion, appetite changes, and hospital admissions. What begins as careful care snowballs into complexity that neither patient nor clinician fully tracks. The danger emerges from three linked problems. First, multiple prescribers may add treatments without periodic reconciliation. Second, the physiologic changes of aging alter how drugs are absorbed, metabolized, and excreted, increasing sensitivity to standard doses. Third, the focus sometimes shifts to disease-specific targets rather than the person's overall functionality. A blood pressure number alone should not trump a patient's ability to stand steady and avoid falls. Deprescribing, the planned supervised reduction of unnecessary medications, is a powerful tool that is often underused. But deprescribing requires time, coordination, and a willingness to accept that risk reduction and symptom control sometimes pull in different directions. Clinicians may fear withdrawing a medication that was prescribed for an important indication. Patients may fear losing protection from a disease they once worried about. These fears are real and must be managed with careful, stepwise plans. Practical steps for patients and caregivers. Prepare an up-to-date medication list for every visit that includes prescription drugs, over-the-counter pills, supplements, topical agents, and herbal products. Ask your clinician to perform a brown bag review. Bring all medications in a bag to be reviewed together. Ask which medicines are essential, which are for symptoms only, and which might be candidates for tapering. If multiple prescribers are involved, request a medication reconciliation by a single clinician or pharmacist. Pharmacist-led reviews often uncover interactions and simplification opportunities that clinicians under time pressure miss. Discuss goals. Sometimes preventing a heart attack in the long term is a priority. Sometimes maintaining independence next month is more important. Aligning medication choices with these goals helps prioritize what to continue and what to reconsider. When stopping drugs, ask for a monitored plan. What symptoms might indicate withdrawal effects? How often will you be seen? And which tests will track progress? Block 9. Power dynamics and the art of asserting preferences without alienation. Healthcare relationships are rarely equal. Clinicians hold knowledge, authority, and access to systems. Patients carry lived experience, goals, and values. When power imbalances go unspoken, patient preferences can be sidelined. But asserting preferences need not be adversarial. There is an art to making your voice heard while preserving collaboration. Start small with scripted phrases that invite partnership rather than confrontation. Examples. I value your opinion, and I also want to share what matters most to me. Could we discuss how this approach would affect my daily life? Or, I'm worried about X. Can we talk about options that help me do Y? These sentences reframe the encounter as shared problem solving. They signal respect and set boundaries. Another tactic is to prioritize issues at the start of the visit. Name the most urgent concerns and the order you want them addressed. That prevents a clinician from focusing on a single lab result while you leave with unresolved priorities. If you feel rushed, ask to schedule a longer appointment or a follow-up dedicated to decisions. Many clinics allow extended visits for complex issues or care planning. When disagreement persists, request a family meeting or a shared decision-making session with a clear agenda. Ask the team to lay out options, probabilities, and likely outcomes in plain terms. Use decision aids when available. These tools often present risks and benefits visually and help align choices with values. If you still feel your preferences are unheard, ask for a second opinion. And if necessary, escalate to patient advocacy services within the health system. Power also operates subtly in documentation. Ask for your goals and chosen preferences to be written in the medical record. A documented note that you wish to prioritize function over aggressive disease metrics changes subsequent conversations. When clinicians see these documented preferences, they are more likely to take them seriously in future decisions. We have named 5 uncomfortable truths. The easy explanation of "it's just old age." The assumption that older people won't follow complex plans. Triage and prioritization that push older adults to the margins. The tendency to underestimate life goals and avoid possibility. And the minimization of emotional suffering. Each truth is a pattern, not an individual moral failing. They emerge where systems are stressed, time is short, and assumptions go unchallenged. You have tools. Bring a one-page summary. Name your goals. Ask for alternatives, timelines, and measurable milestones. Insist on plain language. Request medication reviews. Bring an advocate. When necessary, seek a second opinion and document the steps you take. These are practical acts of partnership that change outcomes. If this kind of content makes sense to you, subscribe now. Share this video with someone who needs to see it today, and help us spread this knowledge. Share with someone special who needs to hear this. Always consult a specialist.